Welcome to this session of pharmacology where we continue looking at drugs affecting the nervous system. Here we're particularly looking at drugs affecting the central nervous system, so we'll first review the CNS and neurotransmitters. We're going to be particularly interested in pain, pain perception, transmission or modulation of those signals. So we're going to look at the endogenous substances. Then we will consider treatment of pain with opioid analgesics. Very briefly, we will look at opioid antagonists and the need for non-opioid analgesics, for example, paracetamol, which we saw had no anti-inflammatory properties, was non-steroidal. It's now, we're saying non-opioid, so we'll look at that term, what opioid means, but paracetamol, an effective analgesic, but we'll see only for mild pain. Therefore, studying pain and looking at classifying it and the different types will be important for knowing which Western pharmaceutical medications are appropriate. So therefore, I need you to review the central nervous system, divided as we saw into the spinal cord and brain. In the brain, I want you to consider the function of the cerebrum, cerebellum, and brainstem. When you're reviewing the brainstem, look at its very important functions at controlling breathing and heart function. Heart rate, rhythmicity, and so on. So review the midbrain, pons, medulla, look at other physiological functions that are controlled there, and you'll see these are very important, vital physiological functions. Then when you look at the cerebrum, review how it is divided into the two hemispheres, each of them connected by the corpus callosum. Also review the basal ganglia, hippocampus and amygdala. We want to review those structures or perhaps physiological arrangements, those systems in the brain that control motor functions or perhaps are the seat of your emotions or affect your emotional state. Also awareness, awakefulness, consciousness, and so on. In the diencephalon, I want you to review the thalamus, the hypothalamus, which is so important in controlling and regulating endocrine functions, and in the diencephalon, also review the pineal gland. So the peripheral nervous system will send signals into the CNS. The CNS, as we will see, will process that information and then send a signal back out again. If it's sensory information coming in, that's an afferent pathway. Review that term. This sensory information is picking up changes inside the body, but also from outside. If it's outside, it's your five senses. It's sound, smell, taste, touch, sight. If it's internal changes, it's muscle tension, blood vessels, pain. That pain might be caused by an external change, might also be caused by an internal change. Okay, so the CNS integrates. It then relays. So therefore, signals will go back out to the peripheral nervous system in efferent pathways, generally motor neurons, but it might be an autonomic neuron, and this will produce necessary adjustments of actions or produce an action in the body. So it's a relay, that's important, between the CNS and the PNS to maintain various bodily functions, to maintain homeostasis. So review neurons. Go back and review action potentials. Don't forget to look at the function of those support cells, the glial cells. We've looked at how nerves can bring action potentials to the nerve terminal, that message can cross a synapse and change an effector organ. Now we're considering that the other structure on the other side of the synapse is another neuron, so we'll call that the postsynaptic neuron, and the one before the synapse, the presynaptic neuron, that released a neurotransmitter that crossed that gap. So there will be neurotransmission, a chemical, to continue the electrical signal and the message that is being transmitted. So it is an electrical signal while it's in the neurons. So we are looking at various ions and their movement, then moving them back with a pump. We might also be studying the channel, the protein through which those ions move, because that's where the drugs might be working. So review those electrical impulse signals, the transmission of the message through the action of neurotransmitters, getting that message to cross a gap and affect the postsynaptic neuron. CNS neurotransmitters are a very complex picture. We've already seen that there are complex structures in the CNS, but furthermore, to mediate some functions and actions, it's several structures, levels, systems within the CNS, and many neurotransmitters involved. We can't hope to review all of them, so concentrate on some excitatory amino acids, such as glutamate. We've mentioned another one there, aspartate. With inhibitory amino acids, we're going to be particularly interested in gamma amino butyric acid GABA. We're interested in this because of its role in pain transmission, perception, and so on. But there are other inhibitory amino acids mentioned, glycine, and some other possibilities that are being studied. Monoamines are neurotransmitters in the CNS, so review noradrenaline, capital N, capital A, adrenaline, and dopamine, capital D, capital A, but serotonin, 5-hydroxytryptamine, abbreviated to 5-HT, and other possibilities where the neurotransmitter is a monoamine. One of them is histamine itself, which may be a neurotransmitter in the CNS. So acetylcholine, definitely a very important CNS neurotransmitter. There are many neuroactive peptides working in the CNS, functioning as either neurotransmitters or neuromodulators. We're going to be particularly interested in substance P, enkephalins, endorphins, and bradykinin because they're involved in pain transmission, modulation, and therefore perception. But as you can see from the list, there are many bioactive peptides that furthermore we can say are neuroactive, work in the CNS, so cholecystokinin, somatostatin, oxytocin, and calcitonin. Purines are also neurotransmitters, adenosine triphosphate being a good example of a purine. These are possibly involved in fast transmission in the brain. So the CNS controls many aspects of the mind: consciousness, behaviour, memory, recognition, but also cognition, your learning, imagination, abstract thinking, your creativity, your ability to reason, and so on. But emotions as well. It is to do with your mental state, that the CNS is one of the major controllers. So therefore, in mental illness, we want to look at the drugs that will affect the various neurotransmitters in the CNS that affect mind, emotions, so on. So let's look at some of them in turn and some of the CNS functions where they mediate. Acetylcholine might be involved in cognition, memory, consciousness, and motor control. We know this from studying the diseases where we see low levels of acetylcholine. This occurs in dementia. Low ACH also occurs in Huntington's disease. So Huntington's disease shows motor control dysfunctions. This is the basal ganglia, basal forebrain, and other structures that are affected. Dementia is a disease where you see changes in cognition and memory, later on consciousness and motor control. So once again, some of the similar physiological systems, the reticular formation or those other structures being affected in the CNS. Noradrenaline is a monoamine. involved in maintaining attention and vigilance, CNS functions. Dopamine, the other monoamine, is a precursor for making noradrenaline, but it is also its own neurotransmitter in certain pathways in the CNS. We do know it's associated with major psychoses. A deficiency is associated with Parkinson's disease. Excess levels of dopamine are associated with schizophrenia, an example of a major psychosis. So dopamine, very important in movement regulation. Once again, we can work this out by looking at the diseases like Parkinson, where movement regulation is dysfunctional. 5-hydroxytryptamine, another monoamine. We'll see later, very, very complex array of receptors. Let's just consider two. 5-hydroxytryptamine type 1 receptors believed to mediate thermoregulation, hypotension, sexual behaviours, but also in people who have overdosed on certain drugs that enhance the levels or the actions of 5-hydroxytryptamine in the CNS, produce this classic syndrome of toxicity, the serotonin syndrome. We saw that that was a triad of dysfunction of motor functions, autonomic functions, and CNS functions. We think that that serotonin syndrome toxicity is mediated at that 5-HT1 receptor. At the 5-HT2 receptor, we think this is where all of those excitatory actions of 5-hydroxytryptamine are mediated. So 5-hydroxytryptamine is just one of your feel-good neurotransmitters. We do know there are alterations in 5-hydroxytryptamine levels in a variety of diseases. Here is a very comprehensive list. Have a look at the list. Notice a lot of them are neurological disorders. Perhaps they are neuroses. Some of them are still in the CNS, migraine, a CNS disorder, vomiting, eating disorders mediated through the CNS. We do know that there's alterations to 5-hydroxytryptamine levels in certain substances of abuse, such as amphetamines, and so on. Many of the drugs that are recreational drugs affect 5-hydroxytryptamine levels, like amphetamines, but many pharmaceutical preparations affect levels of 5-hydroxytryptamine. A classic example given here is one that enhances levels in the CNS, enhances the effects of serotonin, rather than the drug actually working at a 5-hydroxytryptamine receptor. It's not mimicking or working at a 5-hydroxytryptamine receptor. The drug is just enhancing levels of serotonin in the CNS. This is a drug that has selective serotonin reuptake inhibition, that SSRI. The classic example is fluoxetine, a drug sold as Prozac that is used to treat depression. It's an antidepressant because it enhances serotonin in the CS, enhances its effects at giving you those excitatory responses, bringing mood back up and stabilizing it. Histamine might also be a neurotransmitter in the CNS. We know its receptors, H1, H2, H3. We believe it to be involved in altering food and water intake, thermoregulation, various autonomic activities, and hormone release. Also, histamine in the CNS might be associated with causing nausea. Antiemetics might be used to treat nausea. They might be having their action in the CNS where they're affecting levels of histamine as a neurotransmitter. Histamine might be affecting weight gain, having a CNS action as a neurotransmitter, and some antipsychotics and antidepressants might affect a person's weight, have an adverse effect. They might produce sedation. This is another effect that is caused in the CNS, so perhaps it's because histamine is being affected by these antipsychotics or antidepressants, or being directly affected by an antihistamine, and these are causing that sedation. Of course, with antihistamines, we try and, in formulations and in various synthetic forms, try and produce those antihistamines that have less sedation, produce less of this effect in the CNS. Amino acids, we mentioned GABA, gamma-aminobutyric acid, which was inhibitory. We believe then that this GABA might be involved in motor control, spasticity, and in controlling sleep-wakefulness cycles. The excitatory amino acids, glutamate and aspartate, might be involved in neuronal injury, so therefore in certain neurological disorders. There are some substances where they might have a role as a neuromodulator, or they're neuropeptides. Of course, we're going to be really interested in the opioids as neuropeptides. But there are others involved in other pathways in the CNS. Maybe they're a co-transmitter working with a classic transmitter. So things like vasopressin, oxytocin, and secretins, somatostatins, these are all neuropeptides. Another substance that's neuromodulatory is nitrogen monoxide, just a very simple gas. Active as a neuromodulator in the CNS, where we think it regulates the amount of neurotransmitter that's released from nerve endings. There are other neuromodulators. They may be having their action in the CNS or peripherally at modifying pain signals or helping in pain management. We're going to talk about certain types of pain later, and we'll see that anticonvulsant agents are needed to control certain types of pain. Ketamine is an anesthetic, but it might be used as a neuromodulator in pain management. We've talked about how there are some substances in the cannabis plant, tetrahydrocannabinol for example, that might be neuromodulatory. You can use lower levels of opioids if you use tetrahydrocannabinol because it has a synergistic action with the opioid. In the peripheral nervous system, and perhaps also at the CNS level, botulinum toxin might be neuromodulatory, helping it control pain in rheumatoid arthritis, abbreviated to RI. It's being studied quite recently as perhaps being neuromodulatory in its actions. Whatever drug that we develop and study for its toxicities, clinically trial, and then post-marketing study and survey for its ongoing efficacy and toxicities, we want that drug to be as specific for the receptor in the CNS as possible. With 5-hydroxytryptamine, we indicated that it's quite complex though, that there are 7 main types of receptors, and of those 7 main types, there are many multiple subtypes of receptors. Acetylcholine may only have 2 types, nicotinic or muscarinic receptors. Some are known to have more neuronal actions, but acetylcholine is such a ubiquitous neurotransmitter even in the peripheral nervous system, so therefore won't be specific for receptors, will produce more adverse effects. Gamma-aminobutyric acid has one receptor type called GABA-A. We know with this one that drugs such as benzodiazepines bind to their own site on the GABA receptor, not the actual receptor itself where the GABA binds, but somewhere else, and so then in those ways affect inhibitory signals in the CNS where pain perception is reduced. There are other drugs that also work at that same site or related sites, barbiturates, neurosteroids, and picrotoxin, a GABA antagonist, works at, once again, not the actual GABA receptor itself, but at a binding site. In the Western pharmaceutical study of drugs acting in the CNS, one major philosophy or concept is this idea of the disease being a neurotransmitter imbalance. Normally, there would be a balance between the monoamines in the CNS and acetylcholine. Certain disease states, such as depression, might lead to an imbalance, where we saw it might be a deficiency of noradrenaline or 5-hydroxytryptamine, or there might be an increase in acetylcholine leading to that depression. So our drug treatment regimen is designed to re-establish a balance. So at first, as shown here, it might bring back up the levels of noradrenaline and 5-hydroxytryptamine. Similarly, we might want to drop the levels of acetylcholine. In schizophrenia, once again, as we said previously, it might be due to increased levels of dopamine in the CNS. It might be a deficiency of acetylcholine in the CNS that's contributing to that schizophrenia, and so drug treatment and its aim is to bring dopamine levels back down. It might also be, or might thereby cause, increases in acetylcholine levels in the CNS. Parkinson's, we saw, was a deficiency in dopamine in the CNS. That might be also due to an increase in acetylcholine in the CNS. So our drug treatment regimen wants to achieve this circumstance where we bring dopamine levels back up, maybe dropping acetylcholine levels in the CNS to hopefully re-establish a balance. And last of all, consider mania. A person in a manic state might have a deficiency of acetylcholine. It might be that there are also too many monoamines or excitatory amino acids. So it might be an increase in noradrenaline or dopamine, or an increase in glutamate that might lead to the mania. So our drug treatment would want to try and drop the levels of glutamate, or to reduce the monoamines, noradrenaline and dopamine, or maybe to increase levels of acetylcholine in the CNS. Dementia was deemed to be perhaps a deficiency of acetylcholine in the CNS, maybe an increase in monoamines in the CNS. So our drug treatment wants to establish a better balance by dropping the levels of monoamines, perhaps increasing the levels of acetylcholine in the CNS. Another factor to consider will be diet, the person's emotional well-being, other important influences. As far as diet goes, it might be that that dietary substance is a precursor, affecting the concentrations of various substances in the CNS, including neurotransmitters. It might be that there is a cofactor that's needed by enzymes in biosynthetic pathways, and these cofactors will come from the diet. So macronutrients, tryptophan, the amino acid, influences concentrations of serotonin and melatonin in the CNS. Tyrosine, another amino acid, and phenylalanine both influence levels of dopamine and noradrenaline in the brain. Glutamine, an amino acid from the diet, can influence levels of gamma-aminobutyric acid in the CNS. cofactors that are often needed in the synthesis of neurotransmitters. We have B6, zinc, magnesium, and folate. Folate needed to methylate monoamines. Also needed in biosynthetic pathways for dopamine, noradrenaline, also called norepinephrine, and serotonin. So a person might be depressed because they have low serotonin levels in their brain, one of their feel-good neurotransmitters, but it might actually be that what they lack is a cofactor in the CNS. They might not be absorbing B6 from the gut. Zinc or magnesium may not be absorbed. It might be a dietary insufficiency. Folate might be being inhibited by some drug that they're taking, and so this drug is causing effects on their mood and their state, their emotions, and so on, because of this cofactor that's being affected. So all of these things can affect perception of pain. Neurotransmitters in the CNS also have to have their actions terminated by various metabolic enzymes. There are certain substances, drugs, substances from the diet that could promote or inhibit neurotransmitter breakdown. So then when we look at drugs affecting the CNS, we want to know what are the common indications, the clinical conditions that they're used for, but some other factors to consider. For those conditions, the person might be self-administering drugs that have a psychoactive effect in the CNS. They might be taking tobacco, alcohol, or caffeine. They might be taking other analgesics, self-prescribing and self-administering, and this can affect the actual pharmaceutical preparation that is being used to treat their pain or pain syndromes. People are highly unique and variable in their response to pain medications. This can be for many reasons, and when you're studying CNS drugs, you're studying CNS actions. You're looking at the person's memory, emotions, personality or behaviour, and how these drugs might be improving or assisting with those CNS actions. So another thing to consider is that you can't actually study these drugs acting in the CNS in animals. To do your efficacy studies, it has to be done in humans. We need a human response. And we can still study them for their toxicity in animals, but to study efficacy and other aspects of toxicity, we need to study them in humans, and as you'll appreciate, there are ethical considerations there with those studies. So we consider the neurotransmitters for this reason, that most drugs that work in the CNS modify the levels or actions of those neurotransmitters. Similarly, the adverse effects that are produced are often because they have an unwanted effect on that neurotransmission or on the levels of the neurotransmitters. So there are many drugs that we have that affect the CNS. The ones that we will mostly consider, though, as we said, will be those that are used in pain management. So we're looking at directly the opioid analgesics, but we'll see that these other CNS drugs affect pain management. So just to mention some of the other drugs that work in the CNS, anxiolytics reduce anxiety. So a lytic, something that splits, anxiolytic splits anxiety. So benzodiazepines. We'll see that a person's mood affects pain perception. So antidepressants, which also work in the CNS, such as fluoxetine, that selective serotonin reuptake inhibitor, can affect pain management. Sedatives and hypnotics. We'll see that anxiolytics are just used in higher doses to have sedative and hypnotic actions, but we're also going to consider other sedatives and hypnotics, and we're going to consider opioids and their sedative effects. So this will help or hinder pain management. We're going to consider antipsychotics and anti-manic drugs, anti-epileptics and anticonvulsants. They work in the CNS. There is also a link here with pain perception and pain mediation. We're going to see that some anti-epileptic or anticonvulsant medications are used to control pain. Anti-migraine therapies, once again, work in the CNS, work on the neurotransmitters, and we'll see that some of the neurotransmitters that mediate the headache are also mediating pain, pain perception, and pain transmission. And so the anti-migraine therapies will not only be affecting the headache, but the pain. CNS stimulants, such as caffeine, had a synergistic action with some non-opioid and non-steroidal anti-inflammatories that had analgesic actions, so caffeine enhanced paracetamol. Aspirin as an NSAID may also show that enhanced pain control when used with caffeine. So there's dietary effects that also have to be considered. And last of all, we will not look at general anesthetics, but that a drug that induces anesthesia, no perception, no sensory input, will also be analgesic, will block the perception of pain. However, we first have to look at pain before we go on and study particularly the opioids and those other medications that are often used as adjuncts or perhaps might interfere with our pain management regimen using a Western pharmaceutical approach. One important concept is that pain is highly subjective. Only your client can tell you about that pain. It's a symptom. But you can try and use your clinical skills to make observations, gather other signs that will help you measure that pain. It's important to get classifications, types, and so on, and we'll see that that's to get the medication right, or when perhaps it's time to get a person off medication and try complementary or other methods of pain management. So pain has a sensory aspect. It definitely also has an emotional aspect. You perceive the pain in the periphery, but it is actually further modulated and processed in the CNS, so pain perception is both in the periphery and in the CNS. The psychological component that we talked about, it is the emotional aspects that will also influence pain perception, such as is the person anxious, what is their age, are they male or female, what's their cultural background, and normal cultural aspects to tolerance of pain. It might be a previous pain experience that might be affecting the way the person now currently perceives their current pain. Pain is a protective response. We're going to talk about productive and unproductive pain, but if it's a productive pain, it's a protective response, trying to warn the body to act differently, do something different to reduce damage to the body. So we're going to look at it from two aspects. We're looking at a person's ability to tolerate pain. Things that will lower their ability to tolerate pain will be adverse drug reactions, their levels of anxiety. So we'll see, to influence pain tolerance, we might want to take anti-anxiety agents, which we also termed anxiolytics, benzodiazepines, for example. Some things that also influence pain tolerance, the person's ability to communicate that pain. If they are confused under anesthesia, can't communicate, perhaps comatose but can still hear. Their ability to communicate will affect their ability to perceive that pain. If they are sleepless, if they are tired, if a person's angry or fearful, these emotions could lower the person's tolerance to pain. Similarly, depression will lower your tolerance to pain. So to raise the person's tolerance to pain, we might need to use antidepressants that may not themselves have any kind of analgesic action, but they will help with the pain management. So we said previous pain will lower your pain tolerance to your current pain, but sociological factors like your isolation. Common in the elderly for them to be isolated from social structures in their community, and this can influence their tolerance of pain. So things that raise your tolerance in pain: building social networks, social aspects once again, but sleeping well, resting well, using diversion activities. That's what social activities do. They divert a person from thinking about their pain. Counselling, using empathy, could raise the person's tolerance to pain. But as we mentioned, some specific medications, we talked about anti-anxiety and antidepressants. We're going to look at other adjunct therapies. Of course, anesthetics, as they block perception of sense, anesthesia, they will block the sense of pain and its perception, which is analgesia, or else the direct use of analgesics to raise a person's tolerance to pain. To get the drug right, you have to get the pain right. You have to ask the best questions as a clinician. First of all, to work out, is the pain acute or is it chronic? If it's acute pain, we want to know, is it a severe discomfort? Is it, in general terms, sharp? Does it tend to be localized? This is often the case with acute pain. Acute pain often radiates, so you want to ask questions about that. Acute pain often has a sudden onset, so you want to ask key questions that will unlock information about the frequency, duration, and onset of a person's pain. Acute pain would be associated with anxiety, restlessness, increased heart rate, and increased blood pressure, so other signs that you might measure about your client, or looking for sweating and pallor, signs that might indicate that the person is experiencing the symptom of acute pain. And if it's chronic pain, some of the things you might want to find out, once again, the frequency questions. How recurrent is it? How persistent is that pain? What things work, what things don't? You know, aspects of the persistence of that pain. Also, descriptors: dull, aching, diffuse, which will be poorly localized. So acute pain tended to be localized. Chronic pain tended to be poorly localized, but remembering that each person's perception is different and their responses to pain variable. The person might be depressed, withdrawn, expressionless, or exhausted if their pain was chronic. There's also neurogenic pain, where there is a nerve injury. It tends to be a peripheral nerve. There is then dysfunction in that peripheral nerve, but it could also be a CNS nerve, as we'll see, that produces that neurogenic pain. These neurogenic pains tend to be described by your clients as burning, shooting, or tingling pain. So one that will occur in the CNS, but also then in a peripheral nerve, post-herpetic neuralgia. So after a person has had a herpes virus that has actually caused a nerve injury, there'll be this constant perception of pain long after the herpes infection has cleared up, because the person is now experiencing effects due to the nerve injury. People who experience pain in a phantom limb after limb amputation are experiencing a neurogenic pain. Diabetic neuropathy is a dysfunction or an injury in a peripheral nerve. due to uncontrolled glucose levels in the blood, a diabetic neuropathy. This is a neurogenic pain that the person then might experience. These types of neurogenic pain, they don't respond to our opioid analgesics, so that's why we have to talk about some of the other adjuncts or other approaches such as anticonvulsants. So local anesthetics or tricyclic antidepressants might also be needed to deal with this neurogenic pain. Then there's nociceptive pain, where we have a chemical that is stimulating deep or superficial nociceptors. The type of pain that it tends to then cause, how it's then perceived in the CNS, a throbbing, burning, stinging or dull aching pain. But the chemicals are often in the periphery of the body, in the tissues. So the pain might be perceived as deep, or it might be diffuse, it might be a nagging pain if it's this nociceptive pain due to these chemical mediators. Also pain that is perceived from the actions of these chemical mediators, nociceptive pain, might be referred pain. The chemical might be in one body part, but the pain might be experienced and perceived by the CNS as somewhere else. That's a referred pain. Somatic pain, which is nociceptive, responds best to non-steroidal anti-inflammatories. It's only visceral pain, pain from nociceptive stimulation in the chest or abdomen, your visceral pain. That's the one that's going to respond best to opioid analgesics. So you see what we were saying by it's very important, first of all, to develop those clinical skills that you've been working on at getting information from your clients, building up that client history and that client empathy, classifying their pain so as to then do your natural therapies via the best approach. But the same is then also true with Western pharmaceutical preparations that these people may also be taking. So then it's important to consider psychogenic pain, pain where there is no chemical, where there is no nerve injury. Its cause is psychological, psychiatric, or psychosocial, because remember we said isolation can affect how a person tolerates pain. Here, anxiety, depression, or fear of dying might generate pain, a psychogenic pain. This pain can be quite severe when it is caused by anxiety, depression, or emotions, and here a multimodality approach is definitely better than a Western pharmaceutical drug-only approach. So once again, we talked about productive pain and non-productive pain. Non-productive pain is often a consequence to tissue injury, but productive pain is where there is a real tissue injury, where detecting that pain and the CNS then causing you a reaction to that pain, such as, you put your hand on a hot cooking plate, you immediately remove your hand. That's a reflex. You can't stop that or override that CNS action, usually from the spinal cord, to make it even quicker, or perhaps in the CNS using ATP, some other purine neuromodulator to get fast transmission so that you can avert further damage. That's a productive pain. Productive pain doesn't require drug therapies as such. You need to then treat the current further damage, and so the action in itself was enough to prevent sufficient tissue damage. But if it's a non-productive pain, we don't have any control over it. Productive pain is something you do have a control over. As we've said, non-productive pain, long after that injury, it may not be heat, it might be a repetitive strain action, it might be a tear in a muscle and so on. continued pain and continued sending of that signal of pain into the CNS has no productive effect in the person. There's no one behaviour or action that they can do that could then stop those pain signals from going into the CNS. Consider the example here of a person who is experiencing acute and severe pain from a perforated peptic ulcer. Once the person has the message and shows an action, goes and seeks medical advice, logically, in evolution terms, shouldn't the pain then stop? But no, it doesn't. It's a non-productive pain. It will then continue. Drug therapies are needed for this type of non-productive pain, where there is this constant sending of signals into the CNS, or as we'll see, perhaps there's no blocking of it at the thalamus. So get the most accurate description of the pain, if necessary the most accurate diagnosis as to the cause, so that you can get the most appropriate analgesia, be that a natural therapy or Western pharmaceutical therapies or some complementation of both, plus any lifestyle factors and other advice that would be needed to also help manage that pain. Our aim is to keep the person pain-free. Why would we want that? Consider, for example, post-surgical pain. After surgery, the person will actually recover better from the surgery if they're not perceiving pain. However, you've then got to consider dosing, intervals of dosing, when to terminate that pain management, because for post-surgical pain, overdoing the medication might then delay the recovery process if perhaps the person became addicted. They have an addictive personality. We want to avoid chronic pain stress cycles in people during pain management techniques. This just makes it more difficult to manage the pain long term. So therefore, those adjunct therapies, antidepressants, medications that treat sleep patterns, maybe just exercise, and some natural therapies that work on the person's mood or their sleep patterns might actually help them deal with chronic pain better than actually using actual pain management drugs, analgesics and so on. We are going to talk mostly about opioids as our pain management strategy, so there are certain aspects to consider here, especially the adverse effects of the opioids. We're going to talk about this one in more detail, the fact that opioids cause constipation. So anything that you can do proactively, beforehand, you need the opioid for the pain management, but prior to the person becoming constipated, put in place natural therapies or lifestyle changes that will overcome the constipation. We're also going to talk about a step up, step down approach. Here we want to choose the agent right the first time. Increase the dose and potency only where needed. Better perhaps to add additional therapies. Use a stepwise approach then, depending upon how the person then describes the pain or manages it themselves. Is it becoming severe? Is it going back to being moderate? Is it now mild, where you can then change your pain management strategy? Inflammation in tissues leads to pain perception. That's that nociceptive pain. Once again, in your pain management strategy, you want to use anti-inflammatories then to control the inflammation. Some of them will also have analgesic properties, therefore useful for both indications with the one drug. But paracetamol didn't have any anti-inflammatory properties, only had analgesic properties. When you are taking pain medications, or when you have a client who is on a Western pharmaceutical pain management strategy, it's a balance between safety and efficacy. So safety aspects, even with paracetamol, need to be considered. And so this might be weighed into the balance as to what is the most effective pain management. Before we go on and have a look at what would be called exogenous opioids, drugs that the person is taking from the outside and into the body, we have to look at the endogenous opioids. These were bioactive peptides. Remember we said we could also call them neuroactive peptides because they work in either the spinal cord or the brain. So we have endorphins and enkephalins, which are peptides. These are your body's natural opioids, your body's natural process for blocking pain. So consider things that will raise the levels of your endogenous opioids and therefore help in pain transmission or perception. These will also, your natural opioids will enhance the effects of the drugs. But we may not want to use drugs. We may want to use another approach that has a placebo effect. I prefer to say just naturally uses the body's own ability to block its own pain, the natural opioids, the endorphins and enkephalins. So acupuncture is an example here of something that raises the levels of endorphins in the body. By increasing the levels that are released with the use of acupuncture, that person has better pain management and then doesn't need to take analgesic drugs because they're using an analgesic natural therapy. So then we'll go on and consider some of the opioid analgesics. Here we've given a list. We can't hope to talk about all of them. We will use certain examples. And while we talk about these drugs, I want you to be getting clear in your mind the difference between a drug that we describe as an opioid and a drug that we describe as an opiate. So for example, the classic example of something that's an opiate is opium. Here we mean anything that comes from the opium poppy. That's an opiate. Then we may have a lot of substances that are not related to the opium poppy, but work at the same receptors as your endorphins and enkephalins, your endogenous opioids. So these drugs are then just called opioids. So consider this, opiates are opioids. Opioid is a more encompassing term, where an opiate is just one type of opioid. An opiate coming from the opium poppy.